Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Til Luca.
Welcome to the Thinking Practitioner. And welcome again to the Thinking Practitioner Podcast, where Books of Discovery has been a part of massage therapy education for over 20 years. Thousands of schools around the world teach with their textbooks, e-textbooks, and digital resources. Books of Discovery likes to say, learning adventures start here, and they see that same spirit here on the Thinking Practitioner Podcast and are proud to support our work, knowing we share the mission to bring the massage and bodywork community enlivening content that advances our profession. You can check out their collection of e-textbooks and digital learning resources for pathology, kinesiology, anatomy and physiology at booksofdiscovery.com, where Thinking Practitioner listeners can save 15% by entering the word thinking at checkout.
Thanks to Books of Discovery, and today's in-house sponsor is me, Til, at Advanced Trainings. Are you ready to take your skills to the next level? Come visit us at advancedtrainings.com with innovative self-paced programs ranging from 1-hour certificate courses on the most common client complaints to our comprehensive CAMT certification program. We offer practice-changing learning events with industry-leading instructors and a supportive learning community that will take your work to the next level. Plus, for a limited time, Thinking Practitioner listeners can enjoy a special offer. Sign up today at advancedtrainings.com and get a free month of our amazing AT subscription. Explore our extensive library of curated courses, cancel anytime, and keep your credits, all from just $20 a month, with the first month free for you TTP listeners. Enter Thinking Subscriber at checkout on advancedtrainings.com for this limited time offer. Plus, it's not too late to join us for one of our amazing retreats, like our walking workshop with Robert Schleip on the Camino de Santiago, our in-person courses around the country in the coming year, including launching in January our arm, wrist, and shoulder live online course in the new year. Why wait? Visit advancedtrainings.com today. Hey, Whitney, good to see you.
Good to see you as well.
This episode we are airing here was a fun one. Ruth Werner came and visited Colorado and got some work from me while she was here on her chronic cough. We went up and visited APNP and did episode 100 up there with them. But today's episode is a prequel. It was a conversation we had with Walt Fritz, who is well known for his voice, throat, and swallowing disorders work. We thought, let's get Walt on the phone and just talk this through with him. What would he do with Ruth's cough? And can we compare notes and learn from each other? So we had a fun conversation with him. Thanks to Walt for this. And we'll share his contact info and such on the show notes.
And any conversation where you get to listen in on Walt Fritz is a great conversation. So I look forward to hearing all the things that they have to say about working with her.
All right. Without further ado, here we go.
Right.
I want to introduce Ruth Werner. I want to introduce Walt Fritz. My name is Til Luca, and we had this idea. Ruth came to visit me here in Colorado. We had this idea of like picking Walt's brain and comparing notes about working with Ruth's chronic cough. Welcome, you guys. I'm glad you could both join us.
Thanks for the invitation. Yeah,
this is great.
Because I do work with the voice and throat and jaw, and I kind of made it up based on work with a bunch of singers and then some vocal training I had myself, and get great results and really enjoy it and teach it. But then I know, well, that's a specialty of yours, and you've really taken it places and have found a niche that isn't served in many ways.
Yeah. And all I did was I took what I was taught and then made it up from there, like I guess we all do, right? And then so my primary audience is speech pathologists now, and they're like pretty demanding of evidence. So I've done the research in the backward direction that we're not supposed to go, right? You do something and then you find research to support it. But it's been interesting how much is out there and how much is out there for manual therapy, for cough, for swallowing, for voice, for breathing, and all the areas that I specialize in now. So Ruth and Til, it's nice to meet you both. We've not had this opportunity before. So there you go.
Yes.
And Ruth and I are gonna do some hands-on experimentation.
Great.
And you did a little bit.
We did a little bit in Corvallis, but maybe 2 or 3 months ago.
Yeah, and I was teaching a class, and you came down to visit in the lunch break.
It was after class.
It was after class.
You did some exploration of my neck, trying to elicit a cough.
Seeing if we could trigger something. Or
Nothing really came up on that day.
We learned things by ruling them out. It's like there didn't seem to be at that moment, touch or pressure related trigger, at least from the outside.
Yeah.
So that's where we sit.
That's kind of what I do too. And I use the continuum of relevance as my sort of teaching and treating analogy, that I want to do something with you, not to you, but with you, that you recognize. And whether it's, you brought it to my awareness, or, well, that's weird, that calmed it. I don't really care where on the continuum I end up falling. It's as long as you're feeling like, yes, we connected with it. And yes, that's interesting. And yes, this feels like it might be helpful. My work with chronic cough is often sublaryngeal, you might say, behind the SCMs. And I learned this as an anterior cervical approach in MFR, which is now so much more gentle and so much more careful, but kind of getting my fingers behind the SCM, behind the thyroid cartilage. And we've had some really cool, there's a scoping method called FEES, flexible endoscopic something or other, FEES, that they'll go down up the nose, down into the throat, basically. And we've been able to do a number of videos where we're recording the internal image while we're basically messing with people on the outside and watching how the vocal folds respond and react. And also watching how the entire, the whole interior laryngeal complex reacts. Fun stuff.
Sure.
That's great.
Yeah.
Well,
and speech pathologists do that, like, work with the Cs during their lunch break, which is really like creepy to me, but they seem really like, anyway, it's a whole different breed of people. As you guys know, the more you go into different populations, the more of these tribal rituals you see, and that's one of their tribal rituals. So that's where one of the reason I brought that up is that's often one of my first go-tos is kind of moving in behind the SCM and then moving medial in front of the transverse processes, staying clear of the carotids, but then moving medial and trying to explore that retrolaryngeal space to see it starts having any sort of a connection, impact, or influence on the tickle, on the cough, whatever your however you term your cough feeling.
Yeah. So you've said a bunch of good stuff. You're looking to connect with it somehow, either relieve it or provoke it. And I like that fishing. If I get a cough, I got a nibble on the line.
Yeah. And to me, that's that connection, not just here, but up here. That's that sense of relevance received by the person and not just their tissue. And that's really the drum I've been beating for the last 10 years is we're treating humans and not their fascia, not their everything else. So let's just treat them as a person instead of as a tissue.
Well, and one of the conclusions that the conventional medical community came to, I've been through massive amounts of testing of various kinds, but I went through some pretty extensive testing at OHSU a few years ago, and the conclusion, as it has always been, was, "Oh, congratulations, Mrs. Werner, there's nothing wrong with you." And I go, "Oh, that's good news."
Right.
No, but I mean, really what they came to was they called it a motor neuropathy. And, just a hypersensitive reflex rate. And I ended up working with a speech pathologist on learning some breathing methods and some awareness methods that can help me to control it if I have lots of warning. It's not the kind of thing I can do, say, in the middle of a lecture when I get hot, but it is the kind of thing I can do before a lecture to kind of warm things up and reduce the risk that I'm going to get sidelined, by the cough. And that's been helpful. That's been an awareness thing because the more I cough, the tighter I get. And, when I went to see the speech pathologist, who was just a really nice guy, I was up like this and I was breathing really quickly and very shallowly because that's the only thing I could think of to control.
Keep from coughing.
Yeah. And it was a process of learning to breathe much slower. I can't have I am not allowed to take a deep breath. I can't take a deep, full, circular breath. And I resent that with every fiber of my being.
When you say you're not allowed to by the cough?
Right. If I take too deep a breath, I will cough. So I can take I can take a circular breath, but it is just short of being really satisfying,
Yeah.
And I hate that. And I'd like to sing, and I can't reliably, there's a couple of people I'd like to sing with in my town, and I can't make a commitment because I don't know if I'm going to be able to sing.
What does singing do for you? Is it a trigger? Yeah.
Because you change your breathing, and you have to breathe more quickly in order to stay with time. And the sensation of incoming air, if it's fast, I think is a trigger.
Yeah.
But I can get to a point where virtually anything is a trigger. Standing up is a trigger. Sitting down.
Yeah.
So thank
Have you seen the book by James Carroll on chronic cough?
No.
It might be one you explore. It's a medical book, but there's chapters devoted to the therapeutics of it as well, including, kind of touching a little bit on this sorts of work that we're talking about today. But sometimes you just get little pearls, although it's like a stupidly expensive textbook, but still it might give you just a different perspective too on some of those things. And I was in Maryland this weekend, and there was somebody who their specialty was chronic cough, and they were talking about a couple of things that I'd not heard before, specific breathing strategies, and it was something to do with sniff something. And I apologize, but I can't remember the whole thing because I couldn't break in the class to ask about it. But I love my exposure to all these different communities, because you hear all these things. It's like, that's such a different framework and perspective that I've not even looked at. And I guess that's how I got invited and welcome in the speech pathology community, because I'm a unicorn in their world of using this sort of work. But you might find some help. James Carroll is the author, so on chronic cough. Yeah.
Okay, so incoming breath is a trigger. You heard about some sniff thing, which makes me think about a free diving training I did a few months ago, where that's all about breath. It's all about taking full of breath as you can, and especially calming the nervous system. Yeah, that's what allows you to take a big breath and stay underwater for a while. Yeah. And then a couple of sniff things they do to do that, to downregulate.
Yeah. And that could be exactly what she was referring to. I didn't get a chance to question her more about it. And it certainly does sound like, chronic cough is like always you're right at threshold or sub-threshold. And then, the breathing, and that the way you voiced that was both poignant and very, accurate, that I just can't quite get to the breath that I want to take, and I would always, so, if you were coming in to see me, we'd go through a bunch of stuff, but I'd also want to be checking out the concept of checking the diaphragm, or the region of the diaphragm, as I like to say, because, whether it's breath itself or the vagal influence or whatever that might be, and then that whole tie in with the recurrent laryngeal nerve and the vagus and et cetera in the throat region. We act like we know all this stuff, and I know enough to know that there's a connection there. It's like, okay, what can we do with that then?
Right.
I will look to explore with your participation. What are the triggers? Is it the velocity of the incoming breath? Is it the fullness of the breath? What goes on when you cough? And to really take that apart in a minute, understandable way.
Well, what that requires is that the triggers are consistent. And there are days and circumstances where my triggers can be a lot more subtle than other days. Talking about my cough is a trigger, right? And so we're getting bad information, we're getting bad information right off the bat, because just thinking about my cough makes me want to cough.
Yeah.
But when it is at its worst, it just seems like any change in position, standing up, sitting down, laying down, sitting up, a rapid intake of breath is a much more reliable trigger. And then there are these really, really weird ones. Saying numbers, saying, giving my telephone number makes me cough. And I had a therapist say, well, do you ever practice that? Have you ever just practiced saying numbers? And I thought, well, there's a brilliant idea, but it still is a thing. Saying numbers talking with anything in my face. So, a microphone, which is awesome for podcasts.
Yeah.
Or a telephone.
Will trigger.
But also even talking just after having not spoken for a while, the first words that I say after it's like plantar fasciitis and you've been still for a while on the first couple of steps and then you want to cut your foot off.
Mm-hmm.
It's a little bit, it's a little bit like that. Things get stable, they get calm. And then I have to go and say something.
How does hydration influence it? Does it?
I don't notice. Right now, I'm very, very dry because I was flying yesterday and we're here in the mountains. And even though it's humid outside, I just feel really dry. So I have been pushing fluids.
Sure.
I don't notice particularly that makes a big difference for me. But I'm generally pretty good. I like it's partly because I'm very oral. I like having something in my mouth. And so, if it's not coffee, it's water. And if it's not water, it's something else. But I just like to have something moving in my mouth all the time.
Yeah. And I'm not overly blaming a lack of hydration as the thing that's killing society, like a lot of our peers are. But, it is often one of the first go-tos in terms of laryngeal and voice, et cetera, issues is how's your hydration, right? And whether it's in the moment hydration for a fresh, drink, does that affect the cough feeling? Sometimes could even exacerbate it, right? Or maybe the more chronic, the concept of dehydration. You both know it's just so overplayed. But anyway, I'm getting political, and I don't mean that.
But I did notice. So all of this came on for me when I was living in a suburb of Salt Lake City. So I was living at about 5,000 feet. I was teaching. I was lecturing about 10 hours a week. I was singing in a choir, and I was doing a lot of traveling and speaking on weekends. And that part of Utah has the worst air quality in the country because it's trapped between mountain ranges, and there's gravel pits and oil refineries, and this is set up. And that's when there was sort of a major change in my life. I actually changed from really severe yearly sinus type allergies, upper respiratory allergy symptoms. That stopped like overnight, like one season. I stopped having runny nose and itchy eyes, but that's when my cough started. Mm-hmm. So I think somehow those things that doesn't seem like a coincidence.
Right.
But I lived in Utah for 15 years, and I remember feeling when I got to travel to sea level that it was like breathing balm. It just felt so good to bring into my lungs. So I think that the hydration, more than how much water have you had today, but the hydration about your air quality, has a lot to do with that. And now I live in the best air quality in the country, and it's wonderful. And I still have a cough. So.
Right. So, Til, have you done any hands-on with this with Ruth?
Just a couple months ago in that little exploratory session in Dallas. And again, I found things to work with. It felt good, reportedly, but we didn't find a clear tactile cough trigger or anatomical cough trigger even.
Yeah. Did you try any of the that retrolaryngeal anterior cervical stuff?
Absolutely.
Yeah.
And I'm curious now in context. I'll let you finish your thought in a second, but I don't know. I'm so curious about the idea of working with the disturbance as much as the symptom, and certainly even more than the tissue. Mm-hmm. Like, what about it's bothersome to be coughing? And how do you organize around that when you feel a cough coming? And what happens in your body that you deal with a cough? You talked about the shoulders being up and see the pathologist.
And I can often anticipate when it's going to come, which, like that.
Yeah.
Right. And how do I organize around that? I mean,
we'll do that in the session. You don't need to answer that now, but I'm brainstorming in front of my client, which is
not really a regular client.
No,
so.
No. But those are the kind of things I'm going to be wondering, what are the triggers? Can we find a trigger warning? If we find a way to trigger it, and if we can't, what do we learn from that? And then also, what do you do what if we slow it down, super slow-mo, what happened in your body as the cough is on its way?
Oh, yeah.
That kind of process. To see what we can learn there. But I interrupted you. Well, you were going to say something.
That's okay. I'm easily interruptible, and I easily forget what I was going to say. So to me, it's immaterial. You know, the one thing that I do more of now than I ever did was I work with people in a seated position. Part of it was to say, okay, speech pathologists don't have a massage table, even though I do, right? But to me, there's also that getting somebody often into the position of dysfunction instead of the position where we like to work with them. And in reality, I like to work with both anymore, sitting and laying down. And because the dynamics of swallow, the dynamic of breathing are different, right? Do you have any sort of like surrounding the bullseye pieces of any difficulty or challenges with your swallowing at any time?
I am not aware of having problems with my swallowing, but I will.
The answer is no. Yeah.
But I will share with you that when I went through all that testing at OHSU, I told them I live in fear of aspiration. And they told me, you were the least likely person to aspirate because your reflex is so hair triggerable. And so, I am aware that, when you're relaxed and you inhale and a tiny, tiny fleck of saliva gets in the back of your throat, right? And for most people, you clear your throat and it's done. But I might be coughing for half an hour with that. So if there's going to be a positive spin, it's that I am unlikely to accidentally swallow something bad for me.
Yeah. What I love is the richness that you've, over the last 20 minutes, been describing, that the feeling, the anticipation of it, and the minuteness of those. And that's to me, that's the things that I really tap into, Til, is in terms of getting them in touch with that feeling. And it's not just that physical tissue feeling, it's that the psychosocial aspects of that, the anticipatory effect and everything else. That it's just, let's face it, you've limited your life because of the fear of that happening. And without going into Sigmund Freud mode here, it's just so, that's the richness of the experience that I try and tap into. It's like, well, what does it feel like when that happens? And can we do something at all to connect you, not just with that bio, but that psychosocial and everything else that is kind of hooded in that whole aspect of what that cough creates? And that's my approach right there, is can my fingers touch into that feeling? And if we can touch into the feeling, then it's much more than just here, it's happening here. And the positivism of working with the person and not the tissue, I just think is that's where I would head with you, is what I'm trying to say.
And it's, for anyone who ever listens to this, I just want to make it really clear that there's an awful lot in common between living with a chronic cough and living with chronic pain, in the sense that I don't feel like I have a lot of control over it. I have some. I take the control that I can take. And it impacts virtually every part of my life. And it impacts my professional life. I have to be careful about what kinds of commitments I undertake and how I teach. And there's things to say about that. And it impacts my social life. It impacts, people around me know, oh God, there she goes again. She's coughing again. My poor husband has to live with this. And I don't think it's put a strain on our marriage, but that might not be true with any given person. And I'm extremely self-conscious about it. And it's never not part of, I don't feel sorry for myself. It's just, until we start talking about how I'd like to take a deep breath. And I don't feel handicapped or really severely limited, but that's because I have taken steps to create frameworks in my life that allow me to have a cough. And at this point, this has been with me for 30 years. It's hard for me to imagine not having a cough. And I sometimes wonder if this cough is going to contribute to the end of my life.
Well, I can.
For sure.
It is absolutely a psychosocial, whole body, mind, spirit. It's the whole package. Maybe I should make some cough art.
There you go. Right.
Yeah.
That's great. Thank you.
Yeah.
I had a friend here visiting a few months ago. It was actually during,
It's what prompted us to do that.
yeah,
Right.
it was during Diane Metkowski's back jam. And so I put him on the table to show some rib work. And he was actually in Denver to go to the big medical centers there, of like a 5-day eval for his chronic cough. And they did everything. He had to wear like a nasal cannula around for 24 hours, checking the acid in his esophagus and things like this. But when he's on the table, I'm demonstrating some of my rib cage work. It triggered the cough. We found a place in his rib cage that triggered the cough. And he got really interested, and we worked with it a bunch. And in that moment, he was saying, I feel like I'm getting more out of this than my 5 days at the hospital. But we didn't find like the magic switch to turn off the cough whenever he wanted to. But we learned something about.
Yeah, and I think it's really fascinating, Till, what you just alluded to, that sometimes we can find these sort of back doors that, if we're not careful, can get us to feel like, well, we know things that others don't. And at least I'm going to speak in the I way, right? That I may be able to tap into that. I've got a patient with a specific esophageal condition that we can trigger from intercostal work, right? Is it not the thing that's wrong with that person's esophagus, or am I just finding a sneaky backdoor in? But what you just said though, is sometimes the value they get from not just hands-on work, but somebody actually listening to them in a different way can be so instrumental. And even if we don't give them the cure, there's just the sense of somebody really cares. And I think that's the beauty of our shared professions, you know?
I think that was going on there. And I think it was also like, oh, here's a tangible thing that connects to my symptom.
Yeah.
You know, he's wearing these devices around him. Like, do they make a difference? Who knows? We found something that helped him actually experientially connect a dot or two. Yep. And no, it wasn't, there's definitely a hubris possible where I go, oh, wow, we're doing something the doctors didn't do. It wasn't that at all.
Yeah. Yeah.
Have the irony around that. It's like, wouldn't that be weird if this was significant? It turned out to be an interesting insight for him, but no, it wasn't the med. Like I said, the thing he was looking for.
Yeah.
No, but it'd be interesting if you could figure out some kind of nerve flossing stretch or move that might take advantage of whatever cross wiring happened. You know, it's
okay.
Just thinking, right? Yes.
But yet, I don't. Okay, so nerve flossing, dogma aside, I think we're doing that when we're working with somebody. I think we're doing all the different things that people do all these CE for. We're basically all doing it when we touch, not to minimize somebody who can get in with the specificity to say, okay, that's the XYZ nerve. Let's do this, and not that can't work, but I do think there's a lot of more broad, overlap in a lot of our shared works, even though we wall it off as these different type of approaches and different tissues, and how can we not, like in Diane Jacobs' world, how can we not be doing cutaneous nerve flossing when we touch somebody and stretch their skin, even though we think we're releasing their fascia? I mean, it's all coming along. It's all coming along for the ride. And to me, with my thoughts is, I don't know whether I'm flossing your nerves or releasing your fascia or just, taking a lot of money from you, but can I do something that you feel is relevant? Well, it's like, to me, it's the common denominator. What's the common denominator is the therapeutic relationship. And can we build that to the point where, Ruth, you say, wow, whatever you just did, that's getting, just like you said, Till, that's getting closer to something that I've not noticed before. Mm-hmm. And I just think that can be the magic of our work, instead of it all being about the way we pat ourselves on the back for releasing your fascia, Mm-hmm. And I don't make it's not a mystery that I'm sort of an anti-fascist anymore, at least that those old views, but and I poke a lot of fun at it, and I say I'm not serious, but I am serious. I just think we need to stop all this tissue talk and just start treating the human being. And again, the richness and the poignancy that you went out there in this forum right now, and with whoever's going to watch, to talk about how that influences your life. To me, that gets to more important information for me as a clinician than a lot of the other things that we're supposed to test for.
Right. Yeah. No, I agree. That said, there's something to be said for the chop wood, carry water part of our learning and experience that allows us to put that in the background while we observe in every way what that brings to us.
Yeah.
If you don't have that as your foundational stuff, then you're just like reaching into the soup with your bare hands and you don't know what you're going.
You're saying the hands-on technical skills are the foundation.
Well, I think that they have to be part of it. Yeah.
Okay.
Because someone who doesn't know how necks are constructed is not going to touch my neck.
All right. There you go.
There's an interesting argument that comes up a lot on social media groups, in that if you don't know your origins and insertions, that you're somehow less effective as a clinician, or variations on that theme and argument. And it's one that I kind of always take the counter argument that, yeah, I want somebody who's used to touching, who knows anatomy and basic red flags, but I'm not sure whether that really equates to being more effective, but that's my counterculture view, What's that? What?
There's a lot of semantics in there, right?
Yeah.
Because we have to define what's effective. We have to define what are the goals for the person on the table.
Yeah.
Most people do not get on a massage table with the goal of reducing tension in their infraspinatus, but instead to have better freedom of movement in their shoulders so that they can play softball or something.
Yeah. Yeah. And I'm sorry, I'm kind of drifting from your chronic cough.
I couldn't follow that drift.
Yeah.
I'll go there because I think about the fact that anatomy as we know it has existed for 300 years, maybe 4, and yet hands-on body work has existed for probably as long as we've had hands and bodies. And do we really think we're that much more effective because of this anatomical narrative that we have now? There's been all sorts of narratives over who knows how long that I'm sure enable people to do really amazing work with their hands forever.
And then the tribal narratives, that gets even crazier, right? I mean, you guys know the tribal camps are just so strong and people love that tribalism. So
I wonder if there's a thing about our profession, because we have to work in such privacy and in such, sometimes I will call it the sacred pink bubble, right? The beautiful environment that we create that's just us and the person on the table. That sense of isolation makes us cling to our tribe much more strongly.
There's something that
because there are so few people who understand what our life is.
Yeah.
Right.
Well, any other things you want to touch on, Walt, before we?
No, there's certainly my mind just goes buzzing in terms of things that I'd love to do with you, try with you, but that's not the point of what we're doing here. I just,
well, the next year in Portland.
Yeah, you're next. I get her first.
I was just in Eugene not long ago at all. So a couple.
I saw that. That's why I thought of reaching out to you, and I thought,
yeah. And if you want some more local help, just send me an email, and I could kind of maybe hook you up with one of my teaching assistants who's not that far, I don't think so. Yeah. No, it's a, like you alluded to, at some level, it seems so, not to minimize this, it seems minimal compared to some of those massive chronic pain things that people exist with, but yet it's interfering with the quality of your life to an equal, if not greater magnitude as everybody that we see on our tables every day, and I'm sorry for what you're going through, because it's not an easy thing.
Thank you. It isn't. And I feel blessed that I have the ability to create a life that accommodates.
Yeah.
And, maybe someday there will be a day where I don't have to introduce every class saying, hi, you need to know I live with a chronic cough. I'll try and keep it under control, but just so that you know, because I have to introduce myself every single time that way so that people don't worry about me. And I have had classes come to a screeching halt because I got in a jag and I couldn't stop. And that's horrible. That's horrible. I would never want that to happen again.
Okay.
Well, anyway, well, thank you so much for your time. I can't wait to meet you in person.
Yes, I look forward to that. Yes.
Lovely.
And thanks for including me in the conversation. I feel honored to be invited, to have been invited. Yeah.
Really glad it worked out, and I really appreciate the points you've made. I can't wait to try them. And
Great. All right. Cool. All right.
Take care. Have a good day.
Bye.
The Thinking Practitioner podcast is supported by ABNP, Associated Bodywork and Massage Professionals. ABNP membership gives professional practitioners like you a package including individual liability insurance, free continuing education and quick reference apps, online scheduling and payments with Pocket Suite, and much more.
And ABMP CE Courses podcast and the Massage and Bodywork magazine always feature expert voices and new perspectives in the profession, including Til and myself. Thinking Practitioner listeners can save on joining ABMP at abmp.com/thinking. So thank you to all of our listeners and to our sponsors. You can stop by our sites for the video, show notes, transcripts, and any extras. You can find that over on my site at academyofclinicalmassage.com. And Til, for you, where can they find that?
advanced-trainings.com.
All right. And if you have questions or things you'd like to hear from us or hear us talk about, you can just record a short voice memo on your phone and email it to us at info@thethinkingpractitioner.com, or you can look for us on social media under our names. I'm at Whitney Lowe. And Til, where can people find you?
Til Luchau, Luchau. And you can rate us on Apple Podcasts as it helps other people find the show. That really does make a difference. Take a moment, if you don't mind, scroll down and hit rate. Or you can hear us on Spotify, Stitcher, or Podbean, or wherever else you listen. Please do share the word and tell a friend.